Our topic for today's webinar is Dry Eye Diagnostics and Management. And as a speaking delegate, we have Ms. Uh, Prema Chande. She has completed her Masters of Optometry and done fellowship in International Association of Contact Lens Educators, also fellowship of the American Academy of Optometry. She have also completed her PhD and is currently associated with Lotus College of Optometry. Hello, ma'am. Are you there?
Yes, I can hear you.
Okay. Good afternoon, ma'am.
Good afternoon. Good afternoon, all of you. Thank you so much for inviting me and giving me this opportunity. It's truly my pleasure.
Okay. Now I'd like to hand over this session to Dr. Prema Chand. It's our immense pleasure to hear from you, ma'am.
Thank you. Thank you. May I start? Is
Yes,
everybody
ma'am.
logged in? Okay. So can you see my screen? I presume you can see my screen.
Yes, ma'am. We can see it.
Okay. So I think we've all, I'm sorry for this. Okay. I think we've all been uh, doing dry eye diagnostics in our day-to-day practice. So this is almost going to be something which we are already doing, but can do better. And so I would like the session to be more interactive than it being a one-way kind of a dialogue. So what we would like to put in as a learning objective for today's session is basically putting your dry eye theory into practice, which is what I would like to call this. As a clinician, I would like you to look at different techniques for diagnosing dry eye and how to develop a management plan. And as researchers, you can also learn new research questions. I presume you're a mixed group, so I have given both as learning objectives, and also how you can develop a management plan which not only includes home therapy, but also some in-office therapies. So introducing dry eye disease to all of you, we all understand that it affects hundreds of millions of people throughout the world. And it is one of the most frequent causes for patients to visit eye care practitioners. I think if you're practicing, you would understand how many people, nearly 7 out of 10, do come into your practice saying that they do have some form of dry eye. Basically, it's a symptomatic disease which is characterized by a vicious cycle of tear film, instability, and hyperosmolarity, which leads to increased ocular surface inflammation, damage, and neurosensory abnormalities. So if you look at the most recent, so those of you who are really interested in ocular surface disease as a condition, I would strongly recommend you to look at the TFOS site, which is the Tear Film Ocular Surface Organization. So if you get onto the tfos.org site, you will see a lot of updated information. This is a global group which does look at all the recent research dealing with dry eye. So the most recent TFOS report was put up in 2017, and they have defined it as a multifactorial disease of the ocular surface characterized by loss of the homeostasis. So basically, it's an imbalance of the tear film, which is accompanied by different ocular symptoms, which will in turn lead to instability, hyperosmolarity, inflammation, damage, and other neurosensory abnormalities, which all have some etiological role. So if you look at this diagram, it may appear to be a bit complicated, but when you have a patient with a presenting case with dry eye, you could have them in two forms. They could be asymptomatic, they could be symptomatic. So if they're symptomatic, it's simple. There could be some sign of ocular surface disease. You can go about investigating them. So sometimes they could have signs, sometimes they could have no signs, which means there would be no staining, there could be no tear breakup time, but they would have some discomfort which they would be complaining of. So if they are having no signs with symptoms, then there is a possibility that it's a neurotropic pain, and that could be one reason why they could have the dry eye symptoms. If they are asymptomatic, there could be two. Either they have no dry eye, they would be normal people, or they would have ocular surface disease, which because of some neurological problem, for example, like diabetes, there is some neurotrophy set in and they do not feel the symptoms, but you are seeing all the signs of a dry eye, right? So you could have various categories of dry eye. So the simplest is the ones who have symptoms, who have the signs, and they are very easy to diagnose. So again, when you break it up, you could have an aqueous deficient dry eye, you could have an evaporative dry eye, and you could also have a mixed version of both. But in totality, basically, it disturbs the homeostasis of the tear film, and the management goal will always be to restore it. So epidemiology of dry eye, yes, we've had a lot of reports, lot of studies that have been talking of dry eye disease. Anything ranging from 5 to 50% has been reported. I looked up at some literature for Nepal. I found three good studies, again aligning with the international ones, which said 5 to 50%. In Nepal, I found three studies where reported, one study reported 46%, one study is reported 4%, and another one on visual display users, which is basically computer vision syndrome, reported 7.1%. So irrespective whether they are contact lens wearers, irrespective of the age, gender, because women are more prone to have dry eye, hormonal issues, systemic conditions, the range is anything from 5 to 50%, and Nepal is similar to rest of the world. And we've also had some ethnic studies which says Asians are at a higher risk to develop dry eye. So obviously India, Nepal, all of us fall into the same category where we have a higher tendencies, like how we are also highly diabetic tendency, we're also highly dry eye tendency. And so as I said, when we are talking of dry eye disease, you have two large forms. One is the aqueous deficient dry eye and the other is the evaporative dry eye. So this may appear to be, again, a complicated diagram, but you can look at the two categories, which is aqueous deficient dry eye and evaporative dry eye. They have different etiologies, but they all can lead to a mixed version, which will lead to a disturbance in the tear hyperosmolarity. So reasons can be anything from uh, Sjogren syndrome to lacrimal obstruction to contact lens wear to refractive surgery on the surface. This could also be from evaporative, could also be meibomian gland dysfunction, blepharitis, again contact lens wear, allergies, allergy to preservatives, vitamin A deficiency, all in turn lead to a low flow, uh, reducing the making adding changes to the tear film osmolarity, and eventually leading to all the symptoms of dry eye. So basically, when we are talking of meibomian gland dysfunction, we classify it into two categories because this is the most common one. You could have a non-cicatrical one and you could have a cicatrical one. Okay, so these are the two most common among the MGD. So what is MGD? Basically, it's a chronic diffuse abnormality of the meibomian gland, commonly characterized by a terminal duct obstruction. I think this is basics we learn in optometry, right? When the patient is with front of you on the slit lamp, we always, with symptoms of dry eye, what do? We actually like to express the meibomian gland and see if we are having any a thick paste-like discharge coming out, or is it a clear mebum which is coming out. So expression of the meibomian gland is also graded. So this is what we call checking the meibomian gland function. So dysfunction is basically where you could either have a loss of gland or you could have the quality of discharge which is coming out to be very poor. So basically it leads to symptoms of dry eye like irritation. It can also lead to inflammation, leading to ocular surface disease. So again, meibomian gland dysfunction itself can be categorized into hyposecretory, which is like a meibomian sicca. It could be obstructive, again cicatrical, non-cicatrical. It could be hypersecretory or seborrhea, where it gives you a lot of discharge from the meibomian gland. But again, the quality of discharge could be infected. It could lead to dermatitis. It could lead to blepharitis, and so on. So again, although it looks a bit complicated, basically we need to understand there could be various etiologies, from age, gender, hormonal disturbances, to environmental factors like too much of air conditioning, um, uh, poor blinking, sitting in front of uh, uh, display screens. So all of them could also lead to these complications. Contact lens wear is also one of them that actually reduces the thickness of the tear film. So all these in turn can lead to obstruction of the meibomian gland, leading to an MGD. And when we look at clinical cases of dry eye when they present in front of us, typically 85% of the patients would have a dry eye problem. 1% would have a goblet cell disorder. 14% of them would have aqueous deficiency. So when you're talking of aqueous deficiency, these would be your cases with Sjogren's syndrome, lacrimal gland disease, reflex blocks. It could be because of systemic drugs. Contraceptives can give these issues. Drugs used for the treatment of hypertension, thyroid disease, all these would fall under your aqueous deficient problems. Your goblet cell will be typically cell loss because of trauma, LASIK cases, even vitamin A deficiencies. All those will typically be your goblet cell disorders. Whereas meibomian gland will be all your other causes. Sorry for this. So I think I'll just do this. Okay. So how do you begin with diagnosis of dry eye? When you talk of diagnosis, we can use different ways. Yes, we have all your clinical tests that could be done, but the most non-invasive procedures, okay? Like one of the things we learned was that Schirmer's is a very invasive procedure. Avoid doing a Schirmer's test. Although when we've grown up in optometry, we actually grew up saying the best way to pick up dry eye is doing a tear breakup time and then doing a Schirmer's test, right? So try to go as non-invasive as possible. So begin with the dry eye questionnaires. We have very good free resources which are validated. You have the SPEED questionnaire. It's an acronym for Standardized Patient Evaluation of Eye Dryness. You could also have Ocular Surface Disease Index, the OSDI1. So earlier you had the 12-item questionnaire. Now you have a 6-item questionnaire. Both give you similar scores. Then you have the contact lens dry eye questionnaires, specifically for patients who wear contact lenses, dry eye disease among those. So again, in contact lens, you can have a contact lens induced dry eye. You could have a contact lens associated dry eye. So you can have different ones. You can administer these and then pick up those cases. And then, of course, the management part of it. So these are some of the questionnaires. As Kapil said, you're recording it, so you can have these screenshots. You can Google for these. They are free resources. You can download and use them. Okay. We use a lot of OSDI in Lotus. So the OSDI questionnaire is interesting because it gives you different categories. If you do not answer some of the questions, it's fine. The score is calculated based on a quantitative score to your question, and it gives you a color scale also, that how the patient could be anything from normal to severe. But by and large, a score less than 13 is considered a normal eye, and anything above that could be a mild, moderate, or a severe dry eye. So you have evaluation of dry eye. What are the different tests we can do in office? The in-office test would be a meibography, which can be done for the upper and lower lid. This is basically using infrared camera. You could either have a tear evaluation system. You can do it simply with your fundus cameras, which can take anterior images with a special software added to it. You can do a meibomian gland evaluation, just grading the glands from the lower lid and the upper lid, just looking at the gland openings, checking the expression. There is also something, a Corby Blackie test, which I will show it to you. Blink rate. You can evaluate the tear film doing tear prism height, interferometry, T-BAT, both invasive, non-invasive, Shermas, and looking for markers. So let's begin with the eyelid evaluation. The Corb Blackie light test, or the KB light test, is a very simple one where you can actually assess the eyelid closure on how well the lids seal. Because blinking is not just counting the number of times the eye blinks, it's also how well the eye blinks. Is it a full blink? It's a partial blink, because partial blinks could also, or incomplete blinks can also lead to dry eye disease. So here you have how you can measure this. Basically, you grade it into 3 segments: temporal, central, and nasal. And then you can decide whether it is mild, moderate, or severe by looking at the exposure of the lids. So this is nothing but a trans illuminator. You could also use a very, very bright pen torch with a very bright LED light. Of course, the trans illuminators is just an attachment that can be attached to any of your retinoscopes, irrespective whether it's a Hein model or it's a Keeler model. These are the most popular ones. So you can attach a trans illuminator to it. It's just a head. And if you place the light on top of the eyelid like this, the backlight, you can actually make out if the lids seal well or not. You need to just switch off the room light and look if you can see the light leaking. So look at this if you look at this fourth picture which I'm pointing, if you can see the amount of light coming out, which means this eyelid does not seal very well during sleep, or even during blink action, it doesn't seal very well. So this is an incomplete blink. So you can actually measure the blink rate and its completeness, because one of the therapies is not just asking the patient to blink 20 times. You know, in computer vision syndrome, we typically say that, but it is also asking them to close the eye tight. So look at these images. You can actually grade them based on the amount of scleral show which the eyelid has during the closure point. And this actually also correlates with the tear breakup time. The better the blinking, the more complete the blink, the longer will be the tear breakup time. Poorer the blink rate, more the partial blink, then it is actually, you will have a lower tear breakup time. So then you can do the evaluation. I think just examining the eye, looking for vascularization, looking for any meibomian gland dysfunction, lid thickening, staining, gland block. This is your basic slit lamp evaluation, which I think all of you must be familiar with. We also have something called a meibomian gland evaluator, which you can actually use to because with the finger sometimes you end up applying more pressure. The meibomian gland evaluator actually is like a little spring-like device which compresses the lid equal to what the squeezing action will be when the lid blinks. So when the lid blinks, that's the amount of mebum that would be discharged, and the meibomian gland evaluator actually helps you do that. But you can absolutely use your finger, and with experience you will know how much pressure you need to apply. So you can actually look for the number of functional meibomian gland blocks which you have, and basically you can also use this for monitoring your meibomian gland dysfunction. So this is a meibomian gland evaluator. So you can use it by breaking up your, the number of glands which are open and functioning as temporal, central, and nasal. So anything which is functional between 0 to 4 glands, it's considered a dry eye. 5 to 7 is a moderate dry eye. 8 to 10 is a mild dry eye, and 11 and above glands, if they are functioning and open, then it is considered to be no dry eye. So it's your basic evaluation, but you're just quantifying it. Quantifying helps because when you treat the patient, you would know if these glands open up and then start discharging well. You will also know that the treatment is working. So you could use an evaluator. As I said, you could also use your finger. You can also use a bud to do the same thing. The next is using lissamine green stain, you can do that. You can also use, you can debride the lid, you can clean the lid with a cotton tip applicator and then evaluate the lid. So mebography is actually again quantifying the meibomian glands. You can do that by again using a transilluminator, where you can see by placing a cotton tip applicator, you can actually see these glands. You can see the above image, there is no truncation. These black little lines which you can see, there is no truncation, but here you can see the glands are truncated, which means they don't go all the way behind up the lid. So you can do that using a transilluminator. You can also do that using a meibomian gland score using a fundus camera. We use a Trinetra camera. Yes? Hello? Any issue? Can I continue? Okay. So you can actually use a mebography software. You can see here where you can grade the lids with no gland drop, with about 25% drop, which is actually considered grade 1. Grade 2 is 25 to 50% drop. Grade 3 is 50 to 75, and grade 4 is severe, or almost 75% of the glands have been damaged. So that's your MEBO scale, which you can use to do your mebography or grading the meibomian gland. You can also do staining using different dyes. So lissamine green is recommended, especially to look at the lid margin. If it stains, the thickness of the stain and so on, you can actually evaluate lid viper epitheliopathy. You could also do your fluorescent staining, check your cornea for any stain and so on. You can also measure your tear breakup time, get the patient to blink and then not blink and see, wait for the first dry spot to appear, which you can grade on your stop clock. So anything above 10 seconds is considered a good tear breakup time. Anything less than that is obviously towards mild to moderate dry eye, depends. Anything less than 5 seconds is considered severe dry eye. Now, tear breakup time could also be done using any of your Placido disc images, Myers of your autorefractometer, your keratometer Myers. Get the patient to blink, then not blink, and wait for these Myers to break. That will give you your tear breakup time. So this is your lissamine green. You can see the more severe, the more the staining, the more wider the marks line. So basically, when you're using tear film evaluation, we would like to do multiple tests. So you can do a mebography, you can do a tear breakup time, you can do a blink rate, and you can also look for inflammatory markers. So as we said, if you remember the first few slides, which said that we would like to do whenever there is a tear disturbance or change in the osmolarity, it may also trigger an inflammatory reaction in the eye. And this, you can actually look for inflammatory cells because your management will depend on this. So we have a test called MMP9. I don't know whether this is available in Nepal, but it's an inflammatory marker where if you can look at it, it comes like this one here. It's a little thing which you can detach from that, touch the conjunctiva, literally pick up a tear sample, place it back into that cassette, and it will indicate with a colored line from anything from orange to red, which will show you if there is inflammatory cells, it will turn red, and the more red the line is, which you would see, you can see here blue and red lines. So blue is to say that the test is working fine, the first line, and the second line will actually indicate orange to red will indicate whether there is positive inflammation present in the eye. So these kind of eyes that show presence of this MMP9 marker positive are first treated with anti-inflammatory eye drops and then treated along with lubricants. Just lubricants will not resolve this problem. You can also do interferometry. You have a lot of devices that now provide you that option. If you have access to it, why not? It's again a non-invasive test. It actually measures your lipid layer thickness. We have different machines like a LipiView and IDRA, Forest, Huvitz. Many devices actually measure. It actually tells you how good the quality of the meibomian gland discharge or the lipid layer is. Again, lipid layer too thin can also lead to evaporative issues. Too thick could also lead to complications. So you need to have an average thickness. The normal thickness is anything between 80 to 100 microns is the thickness of a normal lipid layer. So this is a video on interferometry. I don't know if it's going to work. It's working fine. Good. So it's demonstrating actually how it is done. Okay. Yeah. See that? Okay, so basically what it gives you is this SBM machine gives you a full profile. We can measure many things from interferometry to tear prism height to non-invasive tear breakup time, and eventually you will get a full output like this. You can see non-invasive tear breakup time. You can measure tear prism height. Gives you interferometry values. It's an expensive device. You can see the blink rate. So it allows you to take a series of photographs of the tear film and then manually compare it with the scale. You can see that. So you can look at it. So you can see here it's captured a series of these pictures and then it allows you to compare it. This one is to measure the tear prism height. You can see basically we can do it even with your slit lamp beam width. So it allows you to take a series of measurements. So as I said, it's a full tear film device which measures interferometry, tear prism height, non-invasive tear breakup time, and so on. Okay. This is for interferometry. Okay, and it also allows you to do a mebography. So this is a complete one machine that allows you to do multiple tests from tear prism height to interferometry to you can also do staining and check. So these are the different diagnostic tests. If you do not have access to an SBM systemy machine or a mybography, it really doesn't matter. If you can do a good slit lamp evaluation used to check if the meibomian gland expression is good, if you can do a good tear breakup time, invasive or non-invasive, is actually good enough to give you an idea whether it is a aqueous deficient or a meibomian gland dysfunction. Another interesting test which you could do is an evaporative stress test where you can actually do this. And in the absence of MMP9, if you want to know if it's an inflammatory response, you can actually see if the patient will get relief by improving the humidity. So you can instill, an eye drop in both eyes and use a scleral lens with it. Use a little bit of sometimes even paracaine or something to see if the pain comes down by putting it in a scleral lens, making the patient wear it for some time and asking them if they are finding any kind of relief. You can also check if it's evaporative by making them wear a goggle and sitting in the office. You can give them instructions to tell every 5 minutes of wearing this. This is an airtight goggle which will actually cause to build humidity inside. It's almost like your swimming goggle, a tight one, which you keep asking the patient every 5 minutes how they feel with it, whether they feel comfortable, whether they feel better, and then again after removing it, every 5 minutes you ask them the question. So if it is going to help them in wearing the goggle for some time, then definitely it's an evaporative one, where by just holding on to it and reducing the evaporation using a goggle, if they are feeling better, if their symptoms are getting relieved, then this is actually an evaporative form of dry eye. If they feel better with the paracaine and scleral lens, then it is apparently a neurotropic one with some inflammatory markers, which is actually triggering the pain. And when you're neutralizing the pain, they are actually feeling, the patient is actually responding to it. So these are simple tests which you can do elimination even in regular practice without any fancy equipment. So once you've done your diagnosis, what is the next? It's going to be management of dry eye disease. So there are different ways of managing dry eye. Of course, home therapy, lubricants is one of the most common things done, but you can also do other adjunct therapies along with it for home. One of the most common ones and the most effective ones is giving them a warm compress, right? Now, we often tell the patient, take hot water in a bowl, use a clean napkin, and put it against the eye. Often the patient is not compliant. Sometimes the temperature is not adequate, because ideally it should be above 40 degrees, 42 degrees, which is what research says should be done at least for 10 minutes. Anything above 6 minutes is what works in terms of therapy. So usually the traditional towel method is ineffective. We can use different ways of doing it. If you really want to give a towel method, because that's the most reasonable one, you can ask them to bundle the towels. You can see here in this photograph how a bunch of 10 napkins can be bundled or rolled in a bowl, okay, which can either be microwaved, or hot water could be placed in it, and these could be squeezed and placed like that, or steamed like that in a tight container with water around it, so it becomes hot, the towel. Then take it out and start peeling one towel at a time from outside and placing it on the eye for 1 minute. So if you have 10 towels like that, starting from the outermost going to the innermost towel, then you will actually do it for 10 minutes with adequate heat. So you can do a bundle towel method. Of course, you can get on to all the heating devices which you get online. You get a lot of these plug and play devices. Amazon sells a whole lot of these Bruda mask plug-in devices. You have these gels with a little chip in. You can bend the chip, it automatically heats. It could be placed on the eye, it could be microwaved and placed on the eye. Whatever works for your patient, whatever they have access to, you can give it to them. Lid hygiene, especially in cases like blepharitis, you can get them to clean standard, the baby shampoo, diluted baby shampoo, but it is good to show them how it is done. Like, often the instructions are not given very well. Today you have access to a lot of YouTube videos which show you how to dilute the shampoo, how to take a cotton tip applicator and literally scrub the lid with it. You can also use tea tree oil for very severe blepharitis cases. Of course, it stings a bit, so only for very severe cases we recommend that. Again, very easily available on all the online sites. So only for very, very severe cases, hypochlor 0.02% is recommended, but usually done in an ophthalmic environment. I would say don't move on till hypochlorous acid, but definitely tea tree, your regular soaps, cleansers are equally good. So teaching them how to do lot of lid wipes we have access to many of these moisturized already lid wipes with surfactants in it available. It's like a blister pack. You can open it, take one wipe, wrap it around your eyelid, clean with your finger, wrap it around your finger, clean one side, wrap the other side of the wipe on the other finger, and clean the other eyelid. So a lot of these lid wipes are available. They are very useful because especially in cases of blepharitis, if you're trying to do warm compress, trying to give them an eye drop, if there is a lot of debris which is blocking the lid gland, no therapy will work till you actually clean and debride the lid. So these are very useful for that. So you can also use your makeup wipes. They are quite good. They're alcohol-based clean cleansers. You can use those also to clean your lids. Of course, there are electronic home devices which, if your patient can have an access to some of these, they can be used to scrub the lids. Very classic for very severe and chronic blepharitis cases. It can also be done as an in-office therapy. So these are some of the lid margin scrub instructions. You can give it as written instructions also to wearers. How to get your towel bundle can be done. This could also be done as an in-office therapy. Get your patient in. If you have an access to a microwave or hot water in your practice, just bundle the towel, get them to sit on your chair and use one towel at a time for 10 minutes, and you can actually treat them. We use a lot of blephastine device at Lotus, which is a plug device, again available from any of the European Amazon sites. You can order for a blephastine device. You can moisten a ring in water, place it inside it, plug it, preheat it for 10 minutes, and let the patient wear it and sit for another 20 minutes, and the therapy is done. So we call them 3 days a week to actually come in and do the therapy at Lotus. Nutritional supplements could be given. Omega-3, flax seeds, very easily available in our markets. You can ask them to consume flax seeds as a part of their meal. A lot of water. Hydration really helps in cases of dry eye. Night time, for some of them, you can give them these goggles or eye goggles which with side shields, which are silicon side shields, which can actually preserve or reduce uh, very useful in evaporative dry eye kind of conditions, where they can use the shields or moisture chamber glasses. Having modifications, some lifestyle modifications, having a humidifier, very high air conditioned rooms. You can recommend this. Actually have a humidifier in one corner of the table where they can just go and sit and get that humidifying air on their face, so that it will actually help them to hydrate the eye too. Giving them good blinking exercises where they can pause, count to, squeeze the lid, again pause, open, squeeze. So giving them a good blink exercise, especially for the ones that we've seen with the car black light, it's going to actually show a lid exposure. A poor blink rate is a reason for it, and actually teaching them a good blinking exercise would also help. This is something which I really use in my practice. You can make these little cards and keep for computer vision syndrome, where you can tell them for every 20 minutes, look 20 feet away and blink 20 times. It helps to relax the accommodation. So you can deal with accommodation, convergence, dry eye, a lot of issues by giving them this rule 2020. There are also a lot of softwares, apps that will pop up on your phone, on your laptops, which would tell you that you need to blink and it is 20 minutes up. And of course, you have all the over-the-counter medications that can be prescribed if you're in a hospital environment and have access to dispensing other medications, antibiotics. You can prescribe, especially if you are in a where the patient is shown positive to inflammatory markers in the eye, or are relieved with pain when when paracaine is used. So those kind of conditions, uh, they may need topical steroids for a duration of 1 week till the inflammation comes down, and then put them onto lubricants. So depending on where you are working, what kind of work environment you are, and if you have access to medication, these could be prescribed. You also have other therapies. This is a neurostimulation one. You can see these two little silicone limbs which actually are placed into the ear. They irritate the nasal mucosa so that they actually trigger a reflex, like how we do a Jones 2 test. So you can do irritating the nasal mucosa so that you trigger where basal um, uh, secretion is low. It triggers the reflex secretion so that the little bit of tear is produced for the eye. So you can use neurostimulation, of course, lubricants. You have a whole variety of these that could be used and prescribed to your wearers. And of course, you have in very severe cases where needed, you may need to do refer the patient actually for surgical options. Could also do in-office therapy. You can do meibomian gland expression. You get these little forceps which you can use. You can use little flat plates like this. So first, get the patient to do steam, then express the gland, debride the lid, and you can do an in-office treatment for your patients with very severe blepharitis and meibomian gland dysfunction. There are also other therapies which offer with technology today, LipiFlow, MeeboFlow. Some of them follow infrared therapy of pulsating the eye with infrared light so that you are actually trying to wake up or activate the meibomian gland. So these are some of the other in-office therapies. Some of these, especially the intense pulsed light ones, are all quite expensive. It's very hard to get patients to pay 30 and 40,000 for a dry eye therapy. But yes, these are also available as an option. As I said, we use a lot of blephastine. We presented papers. It's one of the most um, useful devices to invest in, and not really expensive. So basically, when you're talking of dry eye, you are looking at a multidisciplinary approach. It's not just dealing with at your end for managing the dry eye. The patient may sometimes need a corneal surgeon's support. Sometimes if they may have demodex, they may have dermatitis. So they may also need another dermatologist consult because it's a part of dry eye. Sometimes it's a part of allergic medications. They are asthmatic, they are on anti-allergics that could be giving dry eye. So you need to work with them also to see if they can give alternative medicines which do not have dry eye as a side effect if it is very severe. Sometimes they may need to be sent for pain management. Some of them need also some psychiatric counseling if needed with dry eye. It can be very disturbing, especially the patients with Steven Johnson's or Sjogren syndrome. These are patients who could have a lot of other issues. So you may need a multidisciplinary approach rather than you alone looking at it as an eye care practitioner. So basically what we recommend is when you have a patient, do a systematic approach, do a complete diagnostic, label them dry eye only, because a new diagnostic technique of T4 says they should have an OSDI score above 13 plus any one of the others, like a poor tear breakup time, a poor tear prism height, a low Shermer score, along with an OSDI score, which is when they are actually labeled as dry eye disease. So based on your diagnosis, whether it is evaporative, aqueous, meibomian gland dysfunction, you devise a plan. It could be mixed. It could be treatment with in-office and home therapy. It could be just treatment. It could just be lifestyle correction. It could be in-office plus treatment. So you have to devise a plan what works best, more than one thing. Give it as written instructions to your patient and have a very good follow-up routine. So dry eye patients need to be followed up very closely. Once they are stable for the first 3 to 4 months, then you can call them every 6 months to 1 year, but definitely follow them up at least for a period of 2 years to ensure that you have made a change in their quality of life. So diagnosis summary, as I said, you can do multiple things. Treatment also, you need to devise multiple things. What works best is what you need to try, right? So I'll stop here for questions, and we can take up questions as they come.
Thank you, Dr. Prema Chand, ma'am, for this informative session. Also, thanks to all the attendees for the participation and patience. Now we are to begin with our discussion session. Let me check out the questions for you. If you have any queries, then you can drop it in the chat box. Ma'am, should I read out the questions for you?
Please, and if you want to make it interactive and have the video on, I'm perfectly fine with it.
Mhm. Okay, ma'am. There's what is about tear furning test? Is it reliable like other tests?
Tear?
Tear
I'm sorry, I
furning
didn't.
test.
Furning, F-U-R.
Tear for FERNING.
F-E-R. I'm sorry, I'm not aware of this. I've not heard of a tear furning test. No, I'm sorry. I'm not able to
Okay,
answer
ma'am.
that.
Next, we have a list of tests for dry eye evaluation. Is there anything like this layer of tear film should be evaluated first, or we can go for any of them?
Well, so when you're trying to do the dyes and the staining, we would say run the non-invasive questionnaire first, do your non-invasive test and then do the invasive ones. Like, for example, if you want to do a non-invasive tear breakup time or a tear prism height, do that first and then do your invasive tests like a meibomian gland expression or instilling fluorescent to check for staining or using lysamine green. Do those later, but begin with the questionnaire, then do your non-invasive test, and then do your invasive test. And the dyes and staining should be the last in the battery.
Okay, ma'am. I'll move to the next question. How can you use an sorry, ma'am. Difference between installation of preservative free and with preservative lubrication in dry eye and their outcome.
Okay, so preservative-free dry eye is dry eye lubricants are the most recommended ones for obvious reasons. But we have to remember that there is also a huge cost attached to preservative-free dry eye, right? So you have to see where it is really recommended. When you have cases with allergies or allergic to preservatives, or if you have somebody with Steven Johnson syndrome, those kind of cases where you really need to give a preservative free dry eye, or if they need to use it over the contact lens, then there you would like to recommend a preservative free dry eye. But if otherwise, a preserved dry eye a drop, a preserved lubricant is absolutely fine. So you have to choose between your cases.
Okay, ma'am. Next question. How can you use the neurostimulation? Can you explain it briefly?
Okay, so neurostimulation, if you remember how the device looked, let me try to find it on my so you can actually look up for videos also on neurostimulation. So this is a little battery operated device which can be switched on, and you have to put these two nozzles. One second, I'm trying to get the, yeah. So these two nozzles are put into your nose, one into each nostril. Okay, these two little silicone stimulators go into the nose, and you put on this, push this button. It's a soft button here, it's a rechargeable battery one. So you just push this plus button and it goes on, and it will stimulate your nasal mucosa for about half a minute, and that is enough for you to produce a reflex tear, and then you can stop it, stop the vibrator, switch off the device. So you need what is recommended is you need to use it at least once a day before you are stepping out, and it produces some reflex tearing which would make your eyes moist immediately. So it's a just a natural way of irritating your nasal mucosa.
Okay, ma'am. Next question. Please kindly reflect on dry eye due to hyperosmolarity and its treatment. Also, role of impression cytology for differentiation of dry eye.
Okay, so impression cytology is basically for goblet cell, because you're actually taking an impression of the conjunctiva, right? But by and large, goblet cell issues is typically seen only in, and of course, if there is an evaporative dry eye, then in turn again it leads to loss of goblet cells. So there will be some you know you will see some impression on the cytology. Basically, when you are talking of um, when you're talking of sorry, what was the first part of the question? Come again. I just lost my mental track. For goblet cell, this thing that is usually for goblet cell related dry eye. What was the first part of the question? Can you repeat that?
Dry eye due to hyperosmolarity and its treatment.
Okay, sorry, I got that. So when there is an evaporative dry eye, there is an imbalance. See, we understand that tears have calcium, potassium, all different salts are present in the tears, right? Now if the
Yes.
water and of course almost 78% of the tear composition is water. Now if there is an evaporative dry eye, what happens is the concentration of the salts increase because of water content is reduced. So that is what we call as a hyper osmotic or osmolarity of the tears. How you can evaluate it is we have machines which actually measure the osmolarity of tears. It's called a tear lab. You can take a little sample of the tear, or if you have labs that can actually measure the osmolarity, you can take a sample even with a pipette of the tear, send it to the lab to measure the osmolarity of the tear, and based on the imbalance, you can choose to add what kind of a lubricant you want. So we have teardrops that also come with supplements, with added calcium, with added potassium, with added electrolytes. So those along with the combination. So you could have a carboxymethyl cellulose, you can have a hydroxypropyl methyl cellulose, but some of them would also come with added electrolytes, which can be used to improve the osmolarity of the tears. So a tear lab is actually a very expensive machine, but it does take a very small microliter sample of the tears, and it helps you. You can directly read the osmolarity of the tear from the device off. Yes. Any more questions?
Next, next question, ma'am. Explain about the tear meniscus height and tear prism height. Is it the same or different? If different, then tell about them briefly.
Okay, no, they are exactly the same. Tear meniscus height or tear prism height is exactly the same. You can measure it in the lower lid position. You can actually, if you have a slit lamp, which the width of the beam can be measured using a scale. Often the slit lamps have a scale where you can increase and reduce the width. So you make it horizontal instead of keeping your slit beam vertical. You can make it horizontal, align it with the tear prism height or the tear meniscus height, upper and lower limits, adjust the width of your slit lamp beam, and if you are keeping it at 10x magnification and if your reading is 2, then 0.2 mm is actually the measurement of your tear. So anything which is less than 0.2 mm is considered to be dry eye. Anything which is more than 0.2 mm is considered as a more than 2 mm is considered normal eye.
Okay, ma'am. Next question. What kind of contact lens can be prescribed for dry eye patients?
So we've been seeing that most of the extended wear ones, which were the high water content, very thin lenses, were the ones that actually, absorbed or interfered more into the tear film. So the present generation silicone hydrogel ones that have more moisture in them, they are the ones that have a sustained release. All the newer generation, third generation silicone hydrogels, which are treated, surface treated, plasma treated, moisture added ones, are the ones most recommended for dry eye at this point of time. So very severe dry eye, of course, we do not prescribe lenses at all, because it can actually aggravate and lead to a contact lens associated dry eye. So they would already have some symptoms. You just make it worse, because however good, all the recent studies show that however good the new contact lens surface materials are, at the end of the day, they all interfere into the tear film, and they do give some symptoms of dry eye at the end of the day when the lens is removed. So either if you are forced to give, like supposing the patient were an anisometrope, high myope, needs contact lens for professional reasons, then we have to give it to them along with the lubricant, which we say when you remove the lens, you please add this 1 drop to your eye so that you are comfortable. So most recommended are these kind of lenses.
Okay, ma'am. Next question. Do we have any lubricating component available in market which works well in case DED with inflammatory changes? If any, please give some brief idea about it.
No, when there is inflammatory change, you have to begin with an anti-inflammatory. None of the dry eye. So if there is allergic, we at least have the cyclosporin based ones like Restasis and all. But for inflammatory, they usually, what works best is to put the patient on an anti-inflammatory for some time, like a low dose steroid for a week, and then move them on to the regular lubricants once the inflammation comes down.
Okay, ma'am, there is any other way how to differentiate aqueous deficiency and evaporative dry eye other than Google glasses, as you said?
Those are basically moisture chamber goggles, like just like your swimming goggles. So you'll get it anywhere. It's a very cheap thing, you know. They are just like your swimming goggles. You can even use your swimming goggles actually. So other than that, of course, is trying to do an interferometry, trying to do all your other tests, which would tell you whether it is evaporative or aqueous deficient. So other than that, there is no other way. So using moisture chamber goggles, I think is the most cheap way of doing it, right? It's something which even you and I can do in practice.
Okay, ma'am, there is the last question for now. Can you
Yes.
please briefly say about autologous serum eye drops?
So autologous is basically for patients like Steven Johnson, Sjogren syndrome, where if they are given something from outside, they may throw an allergy to it. So this is basically your serum taken from blood. Okay, it's dehydrated, means it's, if it is like for me, it is my own serum which is taken, which is made anhydrous, and then later you can add saline to it and make your own eye drop and use it. So it is from your own blood serum from which the autologous teardrop is made.
Ma'am, is
Okay, so
there
I
like autologous serums have a lot of complication for like if you use the patient use for 1 week
No,
regularly?
I'm sorry, I
The
cannot
autologous
hear.
serum.
What is it?
Yes, ma'am. What is about autologous serum that people are using for a 1 week and it causes a lot of infection, ma'am. Actually.
No, I'm sorry, your voice is not clear. Something on autologous you're saying, but I cannot hear.
Ma'am, what is about these infections causing the by using the autologous serum because the serum is
Yes, because
extracted
if
from
the
the blood
saline is
again
not
into the throat.
sterile, see, it is not preserved, right? It is not like your eye drop, which has got preservatives in it. So it is an issue with autologous because it's not preservative. It is actually preservative free. So it is also prone to getting contaminated. So it completely depends on how sterile the saline which was used to create it. So it can cause an infection. Yes. So that is why it is not, until unless it's really needed for a patient who is allergic to everything available in the market, only then an autologous is considered. There also they use preservative free saline, and then if it's preservative free saline, they can't use it for more than 1 or 2 days of making the drop because it can get contaminated.
Hello,
Yes. Did you get the
hello,
answer?
ma'am. Namaste. This is, hello,
Yes.
ma'am. This is Ajit.
Yes, Ajit.
Hello.
Please tell me.
Yeah, ma'am. We have experience of using this autologous serum in 2 3 cases. What we used is we used to take the autologous serum and mixed it with the lubricating drop that we have in market, and
Okay.
there is
But
a
then
process
that
how
beats
to
the
dilute
purpose
it.
of
Then
using.
we used it. Hello.
But if you're using another chemical
Hello.
from outside, it beats the purpose of using autologous, na? Autologous is
Uh,
so that you do not use any other chemical from outside which the patient could be allergic
Actually,
to.
allergen has a allergen,
I'm so sorry, I cannot hear you.
but in 3 cases it has very well. We have experience. That's why I share it with you.
Okay, okay. So whatever works, I think sometimes you need to be
Hello,
innovative. Yeah, so
hello.
whatever works for your patient.
Yes, ma'am.
Right. Is that it? Can we call it a day?
Mm,
uh, okay, ma'am. There is one question. Ma'am, is same type of lubricating drop used for both aqueous deficiency and the evaporative dry eye?
In terms of lubrication to alleviate symptoms, yes, but you will also need supplementary therapy when it comes to to evaporative dry eye. Only lubricant will not work. And so in aqueous deficient also, because in aqueous deficient you also need to preserve the amount of tears. So some supplementary therapy like punctal plug, tarsorrhaphy could all be needed in case of aqueous deficient dry eye. And in evaporative you will need other therapy like moisture chamber goggles, steam, all those would be needed.
Okay, ma'am. And there is another question from the Ramayan. So, if the patient can do LASIK surgery, can it cause for a dry eye?
Definitely. In fact, one of the pre-evaluation for LASIK is to check if the patient has mild to moderate dry eye. If they have moderate to severe dry eye, then definitely LASIK is either put away, the patient is treated till the dry eye is reduced, or till the tear status is improved, and all the tear function tests are improved before the patient is taken for LASIK. Otherwise, the patient is not taken for LASIK. It could also be a contraindication, because when LASIK is done, definitely it does damage some of the flora of the eye, both from the epithelial to the conjunctival goblet cell. It does disturb the ocular surface,
The ocular
right?
surface,
And the patient is
right?
put on
And the patient is
dry eye
put on
for a very
dry
long
eye
time.
for a very long time.
All your
Uh,
lubricants for a very long. So if they are already borderline or severe dry eye, then it can only aggravate the situation.
okay, ma'am. Ma'am, what I what I will post the question, the tear fawning test, ma'am. This is basically the biochemical test, and the test is based on the elements or microorganism that have in the tear. And what we
Yeah.
used to do is, yes, ma'am. What we used to do is take a tear from the patient and uh, uh, keep on the micro oven for 10 minutes, and all the liquids water evaporate and give a typical type of fun pattern shape, ma'am.
Okay. Okay. I'm sorry. I was not aware of this. Very good. I'm happy I learned something. Okay. So you study the patterns to see what is the biochemical changes in the tears, is it?
Yes, 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 ma'am.
Okay. All right. Great. I'm glad I learned something new.
Okay, ma'am.
But
So
what we've been
this,
hearing from TFOS is to do as non-invasive tests as possible. So that is why the questionnaires and the non-invasive breakup time and tear prism heights have become very, very popular. Do not disturb. This patient is already in pain. Do not add to their discomfort.
okay, ma'am. Samaya, can you read some question on chat box?
okay. Mm, Ma'am, if there is MGD and ocular allergy at the same time, can we do warm compression?
You could, but you will rarely get that allergy and thing, but yes, you could get it, and you can use these are the ones that could be treated with an antihistamine along with a lubricant, kind of a combination. You can do. Only thing is the warm compress should be avoided, because in allergies we give cold compress, in MGD we give warm compress. So do not give either of them, because it can aggravate the other situation. So just do antihistamines along with lubricants would be perfectly fine for these kind of cases. We do see, right, some of the
Okay.
GPCs can come with the problems.
Mm, yes. And next question: do omega-3 fatty acid really work in treatment of DED?
Well, in some cases I've seen it working, especially when we recommend the flax seeds. A lot of time the patients come back, especially middle-aged, elderly patients, both middle-aged and elderly patients do come back saying that they feel better when they've started consuming flax seeds for a few days, or taking an omega-3 capsule for a few days. They do come back saying it's easier to open the eye in the morning. The light discomfort is less. So symptomatically, definitely we've seen it works. But
Okay.
of course, you will have enough
Then there's the next
literature
question.
to say it works, and you'll have enough literature to say it doesn't work.
What can be other treatment modalities that can be used if we have poor result after regular installation of lubricating drops?
So you can do a combination of lubricating drops with gel in the night time. You can do all your supplementary therapies. So definitely only lubricating drops does not work. Supplementary in-office home therapy is needed. That is why we said you need to plan your entire treatment regimen for the patient. So only lubricating drops would be only giving symptomatic relief. Along with lifestyle correction, so you will have to do a thorough evaluation. Each patient is different, each one's lifestyle is different, and you need to plan the entire management accordingly.
Okay. How can cataract surgery can cause dry eyes, and what can be done as a treatment?
Well, cataract surgery is, of course, again, you're interfering into the fauna. You're doing a surgical cut. You're letting the eye dry up, although they are all the time dripping, lubricating the eye during surgery. But yes, and they are also elderly patients. They've been put on steroids, a lot of antibiotics, oral antibiotics, pre-surgery and everything. So all that is just aggravates the situation. Basically, it's all the mechanical trauma which goes through surgery. So along with the whatever post cataract treatment, the lubricant needs to be added to the regimen. It's just that the patient needs to be explained to give a good 5 minutes gap between each of the eye drop, which will help. The eye drops itself, some of them can lead to dry eye because of preservatives in the drops and so on. So many things. Age is also, mostly your cataract patients are elderly, so age itself is a huge confounder for dry eye. So all these are the etiologies for dry eye with cataract, and they can be managed very simply with lubricants, topical lubricants.
Okay, ma'am. I guess that's all for today.
That's
If
great.
anybody has any
Thank you.
questions, then you can just
Yeah, you can ask them.
unmute yourself and ask the questions.
Yeah, they can also email to me anytime.
There is one question. Post menopause,
Yes.
mostly women face the dry eye symptom. Why?
It's the hormonal changes that lead to that. It's the change in the levels of hormones. So it's not just dryness in the eye. They also have other, their skin feels more dry. There's a lot of dryness in the mouth. So it's an overall systemic dryness. And here the omega-3 really works, because it's not just ocular, it's also systemic. To here, this is one place that I've seen omega-3 really working. And yes, for the ones who are also working, using a lot of spending a lot of screen time, for them it just aggravates the situation, spending too much time within air conditioned environments. So all that just adds to the etiology of an evaporative dry eye. and they could be pretty easily managed with both supplements and topical lubricants. But here the supplements really work, believe me.
Vitamin A, B, C role. If it is there, then how to manage?
Vitamin? Sorry, I didn't get the question.
A, B,
Vitamin
or
A?
C role? B
Vitamin
or
A
C
really helps.
role of any vitamin?
B, I really don't know. C, yes. Calcium, yes. Vitamin A, definitely, because your goblet cells, what is very closely associated in vitamin A deficiency, your goblet cells are the ones that get damaged. So vitamin A surely plays a good role. Vitamin C, otherwise also for overall health, well-being, to deal with allergies, vitamin C is very good. So you can do those as supplements. You can do a multivitamin supplement along with it. But the most documented one is your omega-3. B, I really don't know the role of B.
Okay, ma'am. In post-menopause cases, the dry eye will be aqueous deficit or lipid deficit.
It is by and large evaporative dry eye.
Okay, ma'am. I guess we have answered all the questions now.
Okay, thank you so much. Thank
So,
you.
okay.
Yes,
Here, and
yeah.
considering the time limits, here I announce the closure of the discussion session. Before ending today's session, I'd again like to express my sincere gratitude towards the presenter, Dr. Prema Chande ma'am, and all the attendees. Also, I'd like to appreciate all the helping hands for the iTalks program. Herewith, I'm ending today's session, requesting all of you to drop your reviews and feedback. Stay safe and keep in touch. Thank you. Thank you, everyone.